all four of you for taking the time to join us today. And we can imagine how busy all of you are this month. So really, thank you for that. Dr. Subashini is a dementia consultant with over 10 years of experience in medicine, psychiatry, and geriatrics. She works with Atulya Senior Care and Capstone Multi-Speciality Clinic. She has a master's degree in psychiatry and a postgraduate diploma in geriatric medicine. She is also a passionate advocate and researcher in gerontology and dementia care, and she has often shared her insights through published papers. Dr. Debanjan Banerjee has often spoken in our ST live talks, so he may not be a stranger to many of you here. He is a consultant neuropsychiatrist at the Apollo Multi-Speciality Hospitals in Kolkata, and he is chair IPA Old Age Awareness Week Task Force 2022. He specializes in aging and old age related mental health problems, and he has several awards and distinctions to his credit. He is also involved in regular community programs on mental health awareness and promotions. Bhavana Issar is the founder and CEO of social venture Caregiver Sathi. And Caregiver Sathi, which Bhavana will of course tell us about later, is a high-tech and high-touch platform that supports family caregivers through a care navigation system and gives them access to resources like advice, information, community, professional services, etc. She consults with organizations to build caregiver-friendly and compassionate workplaces that are resilient and innovative. Welcome here, all of you. Rajeshwari is the lead Communication and Resources Dementia India Alliance. She's a seasoned management professional with over 2 decades of experience in corporate, across marketing and financial services in India, Cyprus, Bahrain, and Dubai. She's also been an entrepreneur. And most importantly, she has been a family caregiver for her father when he got afflicted by dementia. There can't be more hands-on experience than that. She's currently part of the Dementia India Alliance as lead communication resources. Dementia India Alliance has been formed recently to assist individuals and families facing challenges of dementia. And Rajeshwari can tell us more about that when she speaks later. So this talk is part of the outreach activities that Silver Talkies does. And for those of you who are not familiar with us, we run Silver Talkies, and you can go to our website, www.silvertalkies.com. We are a social impact organization, and our mission is active and healthy aging. We came into existence in 2014, and since then, we have tried to encourage social engagement, talent, and passion among older adults, which often gets overlooked, and a sense of community. We try to do all these things to engage, empower, and encourage older adults through our events, classes, activities. We have a digital magazine, and we run the Silver Talkies Club, which is a hybrid club open to anyone over the age of 55. And we are very lucky to have members across 12 cities now. So I will not go on anymore. I will open the floor to our Dr. Subashini. You can take it on from here. Thank you so much, all of you, for joining.
Living facility where I'm the dementia consultant, but for the people who are elder and they don't have enough social networking, or they don't have a social life of their own, most of them are like, I don't have anything to do. So this is a very good opportunity for everyone, and I will go to my topic. So I'm just going to cover the basics. Questions, just note it down. I'll answer it towards the end. It is the loss of cognitive function, that is the functioning of the brain, which includes thinking, remembering, reasoning, to such an extent that it interferes with a person's daily life. So why do you need to talk about dementia? because Reshmi was telling us that it has been in a recent study, there are about 8.8 million people affected with dementia in India. This was a study done in 2000, I mean, this was a paper published in 2010, which projected that the number of individuals with dementia would be somewhere around 6.3 in 2025. But the present study, this is the present study that Reshmi was talking to us about. So it has found that the prevalence of dementia in Indians older than 60 is about 8.8. And why we need to know about dementia? Because 90% of them do not get any treatment. While there is no cure, there are a lot of interventions that can improve the quality of life for the persons who are affected with dementia as well as the caregivers. So, as I said earlier, 90% do not get any treatment, and of them, 50 to 70%, they need care, extra care from the caregivers, be it the family or a professional caregiver. And in India, 90% of these people with dementia, the care takes place at home. Unlike in other countries, in developed countries, they have dementia residential facilities. Of course, at present, slowly the dementia residential facilities are coming up. So first, we'll talk about the myths about dementia. So the most common myth is dementia will happen to a person if they use the brain too much or very less. That's a myth. And dementia is not part of the aging process. If there is a problem with memory and it is affecting your functioning, it is not part of aging process. We'll come back to that later. And another myth is there is no treatment of dementia. Yes, there is no cure for dementia, but there are treatments which help the person with dementia to lead good quality of life. And another myth is that, we interchange the word Alzheimer's and dementia. Alzheimer's disease and dementia are not the same. We'll come to that also later. And another myth is people living with dementia don't understand what's happening around them. Although they have memory issues, although they have problems with their brain functioning, we shouldn't take that for granted. And we should understand that they do understand what is happening around them. The only thing is that they're not able to express it appropriately. And we need not correct the person every time they make a mistake. And another myth is only elderly people can get dementia. There is one entity called early onset dementia where it can happen before the age of 65. So now about the facts about dementia. It affects all groups in the society. It affects men, women, rich, poor. It is an illness and it is not part of normal aging.
Perfect. Thank you so much.
Dementia is the name for a group of symptoms that commonly include problems with memory, thinking, problem solving, language, and perception. In a person with dementia, these symptoms are bad enough to affect daily life. Dementia is not a disease in its own right, and it is not a natural part of aging. Rather, the symptoms of dementia are caused by different diseases that affect the brain, including Alzheimer's disease. Dementia is caused by a loss of nerve cells. It is a progressive condition, meaning that symptoms gradually get worse. This is because when a nerve cell dies, it cannot usually be replaced. As more and more cells die, the brain starts to shrink. This can sometimes be seen in a brain scan of someone with dementia. These scans show a slice through the middle of the brain from the front, like looking through the middle of a stick of rock. They show what happens to the brain of someone with Alzheimer's disease as their dementia progresses over several years. Note how the black areas become larger. This is because the brain tissue, the grey areas, continues to shrink or atrophy as nerve cells die off. Common symptoms of dementia include problems with day-to-day memory, concentrating, organising and planning, as well as difficulties with language and visual perception, and changes in mood. However, each person will experience dementia differently, and the symptoms depend on the areas of the brain that are affected. For example, if cells in the temporal lobes start to die, that person might have difficulties with their language. Nerve cell death in the occipital lobes can cause problems with vision. There is currently no cure for dementia, and many of the diseases that cause it are terminal. What is dementia?
So I'm back. So there are disease processes which affect the nerve cells to die, which is called neurodegeneration, which will cause the breakdown of the connections between different parts of the brain. And that results in memory problems, problems with thought, and it will result in behavior problems. So now, dementia is an umbrella term which is used for all the illnesses which have got problems with memory, perception, behavior, language, and personality. There are different types of dementia, which I would enlighten one by one. So the most common is Alzheimer's, the dementia and Alzheimer's disease. The second most common is vascular dementia. Then comes Lewy body disease and frontotemporal dementia. And what we see more often is a mixed form of the dementia. Most of it would be Alzheimer's with vascular or DLB with Alzheimer's. So most of them will be mixed type of dementia. Now about Alzheimer's, what happens in Alzheimer's disease is toxic deposits, which are abnormal proteins that are amyloid beta plaques and tau tangles, get deposited. The black ones are the tau tangles, and the yellow ones are the beta amyloid proteins, which get embedded in the brain. And slowly, the numbers increase, which causes the nerve cells to die, and thus there is progression in the illness. So in Alzheimer's disease, most of the diagnosis of what type of dementia is from the history that we take from the person with dementia and their loved one. So Alzheimer's dementia, it's insidious in onset and it's very slow to progress. And the symptoms also depend on the areas of the brain that are involved. So this is the normal brain, the picture of a normal brain. Slowly it gets atrophied, and this is the picture of the brain in severe Alzheimer's. So these two are specimens, postmortem specimens. One is from a person who didn't have Alzheimer's, and this is from a person who had Alzheimer's. You can note that there is considerable atrophy, degeneration. Look at the size, and these two areas especially, this is called the medial temporal lobe, which is the area for memory, which had atrophied and it has reduced in size. And this is the language area, which has also atrophied. The second most common is vascular dementia, where there is disruption in blood flow to the brain because of varied reasons, like high blood pressure, diabetes, stroke, etc. So there is not enough of oxygen or nutrients supplied to the brain because of the damage of block.
What is the oxygen?
Sorry, may I request everyone to be on mute to allow this to go on smoothly? Thank you so much.
So it happens because of damage or blocked blood vessels. It can happen after a sudden major stroke, and there are strokes which can happen, which are, multiple smaller strokes which go unnoticed because they have lesser symptoms or other vascular causes. And the changes in the cognition happens in step-ladder pattern mostly. There will be noticeable steps downwards from previous level of function. So these are the brain scans where the white areas are the areas where they have suffered low blood supply, and these regions have atrophy. And in the moderate, you can see that whiter areas have increased, and in severe, even more. So the next type of dementia that I would like to highlight is dementia syndromes, which are associated with Lewy bodies. There are two types of Lewy body type of dementia. So one is the Parkinson's disease with dementia, which happens in Parkinson's disease as it progresses. And dementia in Lewy body is similar to that, except that the Parkinson's symptoms occur after the other cognitive symptoms have occurred. So there might be changes in thinking, reasoning, and the hallmark is fluctuating cognition. They will appear to be normal during certain times, and they'll become cognitive. They'll have difficulty with cognition certain times, and they will also have Parkinsonism symptom, as I've mentioned earlier. They'll have slowness of movement, rest tremor, rigidity as well. And the next dementia that I would like to highlight is frontotemporal dementia, which affects mainly the frontal and the temporal lobes of the brain, the front and the sides. Why I've highlighted this type of dementia is because it usually presents with behavioral changes or language changes, and the memory problems occur only later. So there will be sudden change in their personality. They might act inappropriately, impulsively. Their hygiene might come down, or they might have language problems, like they'll start searching for words. They'll struggle making a sentence fully. So usually the personality problems will be viewed as other mental illness, and they'll be treated initially, but it won't respond to those treatments. So in that case, we think of frontotemporal dementia. So this is the trajectory showing how normal aging, the cognition changes in the normal aging is. The green arrow is the cognitive decline, which is a part of normal aging. The blue one is the mild cognitive impairment, and the dark blue and the orange ones are the trajectories of dementia. So there is some cognitive change during aging, and we'll cover that now. So what happens? What happens in cognition as we age? So mental processes naturally declines. There is cognitive slowing. Our language, vocabulary, verbal output, everything remains unchanged. And our ability to focus on a single task also remains unchanged. There will be some difficulty when we try to multitask or switch our attention. And the general knowledge and the crystallized intelligence are mostly unaffected. When we try to use our skills and knowledge, it will be unaffected. But when we want to, our ability to switch between tasks or solve new problems will be affected, which is called fluid intelligence. Now we have to keep in mind that when our daily functioning, our everyday activities are not affected, we need not get agitated, we need not get worried. The next in the trajectory is the mild cognitive impairment. This is the transitional gray zone between normal cognition and dementia. The symptoms are mild. They will have forgetfulness, impulsivity, difficulty maintaining a train of thought. And this will be of concern to the family and the individual, but it does not interfere with the person's independent functioning and their overall cognitive state. So they'll be still able to do complex tasks. So next is dementia. In dementia, the cognitive decline becomes more amplified. It gets reflected as personality changes. They'll be confused. They'll have problems navigating familiar environments. They'll have difficulty performing everyday tasks as well. So these are the common symptoms, and just touching on it, Dr. Debanjan will highlight us with more of his insights. So the most common is the memory loss. It is like, usually it starts with problems with short-term memory. So when we have clients visiting us, they will be like, my short-term memory is affected, but I can remember what happened when I was a child, or what happened during my school or when my children were small and all that. So it usually starts with short-term memory loss, and slowly it will progress on to losing the long-term memory as well. So there will be challenges in planning, solving problems. They will have difficulty in completing familiar tasks and activities. They'll also get confused about time, place, people, and they will also have wayfinding difficulty. Initially, the difficulty will be when they go for shopping or when they go out for a walk. They will find it difficult to get back to the place they want to. And slowly, as the illness progresses, they'll have problems finding their way inside their house itself. The other symptoms include they'll have, as I said earlier, there'll be problems with their language. It can be them using words in, like speaking or writing. It can also be the other way around. They'll have problems with comprehension as well. They'll start misplacing things, and they have decreased or poor judgment, and they also withdraw from social or work activities. They'll also have changes in mood and personality. So this is how the illness progresses. These symptoms will also progress with the illness, and this is how we will be able to know that how faster or slow the illness is progressing. And for example, if it is memory impairment, initially they'll start with misplacing things and searching for them, and slowly it'll go on to their forgetting recent events, and they'll repeatedly ask questions like, did I have my lunch? Did I have my breakfast? Did I take my medication? Or it'll be like, when will you back? And slowly that will progress to forgetting distant relatives, their faces, etc. And slowly they'll forget names of their loved ones and so on. So what do we do? If we are worried that our memory is problematic, what do we do? So we need not worry. Besides dementia, there are other causes for memory impairment, some of which I have mentioned. It can be because of stress itself. It can be because of depression. It can be because of pain. It can be due to chronic illnesses, medications, alcohol, etc. But major changes in memory are not normal. It is better we see the doctor sooner. There are early assessments help in early diagnosis and treatment, and which will help in planning by the family members as well. What does the doctor do when you go to a doctor with complaints of memory disturbances? So the doctor will take a detailed history about the memory, when it started, how it progressed, how is it affecting your daily life, the other physical and other comorbidities that you have, about the medications that you take, and we'll come up with a diagnostic formulation. And then we go on to the cognitive testing. There are a number of pen and paper cognitive tests that can be done to assess the cognition. And later we ask for blood investigations to rule out reversible causes which causes cognitive decline. And we also ask for the brain scan, such as CT or MRI brain, to rule out any acute causes and to be sure there are no space-occupying lesions or any tumor in the brain. So I'll just slightly touch upon how we manage dementia. So there are pharmacological and psychosocial interventions available. Pharmacological interventions can be given for the memory as well as for the behavioral problems. And psychosocial interventions also help with the cognition as well as with behavioral problems. So the treatment domains include, actually there are 5 domains that we have to manage when it comes to person with dementia. Is not only the memory. So we take care of the cognitive functions. We help people with medications and interventions. We also advise them about their activities of daily living, like brushing, bathing, eating, dressing, etc. We also have the tab on their physical health. We see to it that their sugar is under control, their blood pressure is under control, and all other medical problems are under control. And about the behavioral and psychological symptoms, Again, we have pharmacological and non-pharmacological. And the final one, the caregiver distress. Whoever is taking care of the person with dementia, we see to it that they are not depressed, they are not burnt out. If at all they are, we help them with it as well. A few slides on risk factors for dementia, because hearing all these, most of you would have become a little bit nervous. So what can we do? So this is a paper from Lancet Commission, which is a systematic review. They would have analyzed a lot of papers which had done research on the risk factors for dementia, and they've come up with a few risk factors. So some of the risk factors are less education, having hearing loss, having a traumatic brain injury, hypertension, diabetes, which is not under control, use of alcohol, smoking, social isolation, obesity. And I would like to insist on less of physical activity as well. So these are the modifiable risk factors. So lifestyle changes and maintaining your health do help in postponing or preventing dementia to some extent. So now that there is no cure for dementia, what we can do, we can look after our heart, we can look after our sugar levels, blood sugar levels, be physically active, follow a healthy diet, mentally challenge your brain, keep your brain active, and also please do enjoy social activities.
Okay, so very good afternoon, everyone. It's great to be back to Silver Talkies event again, and it's always good to meet you all. I've seen, some of you have met me times before. So yes, I think we are here together because of Alzheimer's, World Alzheimer's Month, and thank you to big thanks to the Silver Talkies team for having me here, and it was a great presentation by Dr. Subashini. Looking forward to Bhavana Issar's presentation as well. So and the panel discussion. I think when we talk about matters in a more informal fashion, we get to know much more about such a complex thing like dementia. Now, what I'll be talking about is primarily, I'll keep the focus on mainly Alzheimer's disease. Dr. Subashini has mentioned very clearly about the different aspects of dementia, the different types. Some of my presentation slides or matter of discussion may be a bit repetitive, so I try to avoid that part. And also I'll be discussing about caregiving, since it's a very, very important aspect of dementia management. I mean, many of you here may be affected. Many of you are taking care of your family members who have Alzheimer's or other forms of dementia. At the outset, I'd like to focus that if the caregivers do not stay well, you know, the whole essence of caregiving kind of goes down. So the caregivers form the central part of the dementia story. Today's topic is the story of dementia, and we tend to talk a lot about people who are affected, but what about those who take care of them? You know, I remember, to start off with this, I remember one of gentlemen who used to come to me regularly, and he was diagnosed with Alzheimer's. So one fine day when his spouse was also there with him, and I asked him that, you know, how are you doing? How are things and all? After the whole discussion happened, his wife asked me, you never, doctor, you never asked me how I am. You just kept asking him how he was. So that was a very important part of the whole thing, that we often tend to forget to talk about the caregivers and their caregiving, because that becomes such an important part of the whole scenario. So Reshmi, I'll be sharing my slides. Is that okay? Yeah, so, you know, I kind of am also happy to be here as a part of the IPA, of which, you know, we are also having the IPA task force on old age mental health awareness week, which starts from 1st October, which is the United Nations Day for Older Persons, which lasts till 10th October, which is, oh, I'm sorry for the interruption, and I'm in my clinic, so that may happen once a while. So I think this part has already been discussed, as Dr. Subashini mentioned in detail about what is dementia. I would like to stress on two factors here. Now, we all know that dementia is associated with forgetfulness. But you know, for a long time, memory has received a very undue attention. Everything about dementia was memory. In fact, most of the times when, let's say somebody comes and tells me that, you know, so-and-so forgets things, everything is almost subsumed that, you know, it's forgetfulness. Let's say somebody who forgets his or her specs, forgets the way to the bathroom, forgets names, forgets the way back home, is not able to multitask, and yet it is considered in forgetfulness. Doesn't smile when a person sees another person, and even that is encompassed within forgetfulness. So what's important to understand here, that even though most dementia are Alzheimer's disease, and they will, they will be seen with this long-standing forgetfulness, memory problems, direction issues, some will also come with problem in language, not able to tell the correct word, mispronunciation of words, not recognizing familiar faces, problems in social behavior, inappropriate social behavior, sometimes, a bit of wandering tendencies, sugar craving, change in dietary patterns, these are also seen. So in all these cases, it's important to keep your antenna open and consult your doctor as soon as possible, because there can be different shades of dementia. The other important factor is we all will tend to forget a bit with age, and that will increase with time. So a person with 65 years will of course have a better memory than somebody who is 85. But as Dr. Subashini was mentioning about mild cognitive impairment, it's a spectrum. So normal forgetfulness to mild impairment to the different stages of dementia. And it's not that a person starts to have dementia all of a sudden one fine morning. It's a process which goes on for sometimes years altogether. And it is possible to delay the process in many ways, be it medication, lifestyle changes, and so on, which will come later in the presentation. So many times you will see that in a society, particularly our society, we talk about it that when a person is aging, it's quite normal to forget. So forgetfulness is normalized based on age. That's not always the case. And it's very important to understand that what the individual used to do before. So what were the level of the activities that he or she used to do before? That has changed now. The profile of a person who is being teaching in a school or college will be very different from somebody who has spent most of their time in a shop versus somebody who has spent a long time working in the farms or working in farming. So many times in our society, when a person ages, they have a lot of social support, people doing things for them. So what's expected out of them probably reduces a bit. So when the dementia comes to attention, or when the forgetfulness comes to attention, is very important. And that solely depends on, or what we ask is, or as caregivers, what you can ask is, how has the routine of that particular person changed? So does he or she need more help to do a particular thing? Has it become more stressful and strenuous for them? Somebody who was easily able to go remember a list and come back from the market, or somebody who was able to, let's say, do household work or cook for multiple people together, or somebody who is able to work in the office for a certain period of time, does it take more time, more energy, and more effort to do all these? And even that can be early sign of dementia. Again, this has already been covered in the last presentation. Alzheimer's is the commonest type of dementia. We also have dementia that happens out of multiple strokes, which is vascular, dementia with Parkinson's, which is another neurological illness, and frontotemporal dementia, which is more associated with social and language problems. Forgetting things is not an exclusive thing related to dementia. So we also have problems in attention. If you are very bored with a movie, you will not really remember the narrative or the screenplay or the characters. Now, that's not anywhere related to dementia. That happens because your attention was not proper. Depression and many times when individuals come to us, especially at an older age, forgetfulness can be the first and the most prominent sign of old age depression. Anxiety and depression is so common. And nowadays it's very underdetected, but most individuals, when we treat depression, we see that the forgetfulness is almost gone. That doesn't mean that every individual with dementia has depression, but most people who have depression do have a risk of forgetfulness. Prolonged stress, recurrent lack of sleep, lack of social interaction. At the times of COVID, many people were segregated, they felt lonely, individuals who stay in old age homes, who do not have frequent contact with their family, all of which is related to or can be potential risk factors for forgetfulness. This is the global impact of dementia. This is again a slide, a data collection from the World Health Organization. I won't scare you too much with the statistics, but one individual every 3 seconds get detected. And imagine in a population like ours, what can be the magnitude of such an increasing population, especially when we are going through a rapid demographic transition. The number of older people are really increasing. So it's concerning, and we need to be prepared. All of us, not just the medical professionals, need to be prepared for the shift. This is a 2021 banner from the Alzheimer's Association, which shows that the number of deaths in individuals with Alzheimer's have increased significantly during COVID. 1 in 3 individuals who have dementia has an enhanced death. There is increased risk of other mental health conditions, and the total numbers are expected to double by 2030. Interestingly, there was a study that came quite some time back. It's known as the 1066 Dementia Project. Why was it called 1066? It's very interesting that more than 2/3 or 66% of individuals who live with dementia in the world, they come from lower and middle income countries. However, only less than 10% of research or resources or data or services have been dedicated to those 67%. Hence the name 10 by 66. So imagine the magnitude of the problem and how we can all help. I'll skip this. I think this already been repeated. So here you can see Aloy Alzheimer's. He was a neurologist, and he was the first person to name Alzheimer's disease. What you see on the right side is Miss Auguste Ditter, and she was the first person to be detected with what we call as Alzheimer's disease today. And based on her findings, this illness was named. Very interestingly, the age of the first person who was detected with Alzheimer's, Auguste, was pretty young. She was roughly in the mid-50s. But today, what we call as Alzheimer's is more prominent in people who are 65 and above. Even though early cases do happen, they are very rare and they do carry a genetic risk. So, this is a spectrum, as I was mentioning, and just having dementia means nothing. It's important as to what the individual can do, whether it is interfering with the activities of daily living. There are 2 types of things. One is what you do every day. Eating, bathing, brushing is something activities of daily living that gets impaired only when the dementia progresses quite much. Up to mild dementia, what will be a problem is what we call as the instrumental activities of daily living. So let's say, going to the market, shopping, planning your day, running bills, paying, somebody, organizing your work, and so on. So it's what initially gets affected. Again, this is, if you can see the slope, you will understand how the disease process kind of progresses, the areas of the brain that tend to get affected. And nowadays, there is a lot of discussion about the preclinical phase, the pre-dementia phase, which lasts for quite a long time. So there is a lot of things that we can do during that phase, provided if we can detect. And hence, earlier diagnosis, earlier screening of dementia, especially Alzheimer's, becomes so important. And here is where all of you can play a role. Here is where such programs become so immensely important. In an illness which is progressive, which does not have a fixed medical cure, but so much can be done in early stage. So, each of us can be a gatekeeper, a flag bearer to detect those persons who are in need of care, so that there can be a lot that can be done. This is, again, what you see is influence of multiple factors. The genetic part was mentioned by Dr. Subashini. Also, the other lifestyle factors, which she mentioned in the towards the end in the Lancet's paper, is physical activity, education, and in today's world where most of us are very busy gazing at our screens every time, socialization forms a very important aspect. The metabolic or the vascular risk factors, high BP, sugars, obesity, high cholesterol, repeated strokes, the risk that smoking and alcohol can predispose to hearing loss, and very, very importantly, depression, which can also be a forerunner of dementia. So these are the different neurological mechanisms. We won't go into the technical terms, but what's important is that the brain reduces in size, and eventually there are neurons that get damaged, nerve cells that get damaged in specific areas of brain. So again, these are the risk factors. I'll also briefly allude to this towards the later part of the presentation. These are the certain genetic risk factors. Of course, being older itself is a risk. Even though many people ask me, I think, many of you get these questions as well. Alzheimer's or dementia is not a one-to-one genetic illness like thalassemia or hemophilia. It has a genetic risk. The more the number of family, first degree, second degree relatives you have, the more is the risk. But genetic risk alone doesn't lead to dementia in most cases. Lifestyle changes and head injury is a very, very important factor. These are the common symptoms, very early, that you can identify. Try to keep it as simple as possible. Memory is one aspect, but having difficulty in complex tasks, misplacing day-to-day items, problem-solving issues, sometimes emotional outburst. Person who has been very calm all throughout can suddenly get agitated, having difficulty in words. There is a pen, but instead of that, somebody tells, oh, where is that thing? You keep asking what thing, and the person tells, oh, something with which we write, but that word pen doesn't come out. So that's the problem with vocabulary. Having issues with estimating space, which happens in type of Alzheimer's, which is called posterior cortical variant. You have problems with depth perception. Person may bump into windows, doors, in different places, and that can even lead to head injury. And finally, many individuals, when they realize that, I am not able to do the thing that I used to do before, can get depressed. They can withdraw themselves from the society in various aspects. This is again kind of a repetition where social withdrawal, changes in vision, and problems in task can be identified as early signs. This is again, I will rather avoid statistics. I think already that's been discussed in the last presentation. Coming to a very important aspect, something that, as psychiatrists, we primarily deal with, behavioral and psychological symptoms of dementia. Inevitably, in most people who have given care for your loved ones who have Alzheimer's, you have seen one or more of it. Sleep-wake problems, problems in sleeping, sundowning, which means that the behavioral issues turn to be more towards evening time, wandering around, living in islands of memory in the past and enacting them, getting agitated, resistance to daily based care, resistance to taking bath, to going to bathroom, having food, sometimes inappropriate social behavior, management of inappropriate sexual behavior is a separate thing altogether, hallucinating, suspiciousness. Many people have that somebody is there in my house and somebody is watching me, which is called imposter syndrome. Verbal aggression and depression is again a very, very common factor. Remember, individuals who have dementia are very much alive and their identity is very much there. Just because they are not able to express doesn't mean that they're immune to mental health conditions. So that's also important for us to remember. What are the triggers? PTSD doesn't happen in a vacuum. So just prescribing medication won't help. Many times, pain, infection somewhere in the body, constipation, very loud noise, bright light, chaotic environment, hunger, sodium going down, potassium disturbances, problems with blood sugars, prostate issues becomes extremely important. And finally, always make sure to check every single prescription. Sometimes a person may be getting 3 different multivitamins from 3 doctors. Many times in a busy OPD, we do not manage to see the other prescriptions. In this age, and a person with dementia, multiple medicines do more harm than good. So polypharmacy is another factor. COVID-19 have, of course, increased the deterioration and also increased the number of deaths due to social isolation. And prevention is a very important factor. So omega-3 fatty acids, green tea, fresh plant foods have shown some evidence. Now remember, these are not treatment of dementia, but they do have a preventive aspect, and keeping the brain active is a very, very important task. In our common proposition, we mention use it or lose it. So either you use the brain or you tend to lose its benefits. So that's something that is very important. What are the red flags? When do you think that it's a medical emergency and, or probably you need to seek help as soon as possible? Sudden change in social behavior regularly. So here is how you differentiate from a normal age-related forgetfulness versus somebody who's having dementia. Somebody is continuously isolating themselves, repeatedly losing weight, has got lost sometimes, problems in naming, change of behavior, problem with regulating urine and motion, and when it starts affecting personal and professional domains. I think this has already been discussed by Dr. Subashini. So in terms of treatment, medicines do not cure or reverse dementia. The medicines that we have today can slow and delay the progression of illness. It can delay by years, depends on each individual. It can reduce the behavioral and psychological symptoms. It can give a good quality of life to the individual and the caregiver. But along with that, there is a lot that can be done. The very fact that we are all together sitting today and discussing these issues is one of the first good steps. Educating the caregiver, informing them about something important, keeping the brain active. We always tell that even if a person is forgetting, let them watch the news, read the newspaper, talk to people, even if they're not providing their opinion. Sitting amidst a group discussing an issue can itself be activating to the brain. And it's important to rehearse. So just reading or just looking at something or just watching the TV is not enough. After that, ask them, what did they see? What was the character? Try to make in a story and talk to them. And that becomes very important. Sometimes people will be restricted to those islands of memory in the past. I'm also talking here as a caregiver because my grandfather had Alzheimer's for long, and I have seen him both before I became a medical professional and after. And he kept on talking about the 1970s riots that Bengal had faced and all the turmoil that happened that time. And I always used to let him speak about it. And he was so happy that somebody was there who doesn't just dismiss him, telling that, this is different year, this is past that long back, and you're not living in that past anymore. But living in their world is our responsibility. they will not come and live in our world. And understanding that becomes extremely important. So seek professional help, discuss your challenges with your doctors, supervise the medications, avoid polypharmacy, keep the person engaged, try to maintain a routine, and dignity becomes very important. So there is something called reminiscence therapy. We usually bring in old photographs, memories, try to discuss it with them, and try to validate their emotions, which becomes, again, very important. Group activities involving in senior citizen forums, again, thanks to the wonderful work that Silver Talkies is doing. And physiotherapy also helps because many of them have slow mobility. One thing I thought of highlighting that, and this we had this discussion before as well, women have, there is a strong gender bias to Alzheimer's. Women tend to be detected lesser, but tend to be affected more, but they tend to live more with Alzheimer's as well. And it is not only those who are affected with Alzheimer's, even there is a lot of discussion about women caregivers, because there is a lot of difference in social strata, change in dynamics, understanding, and also detection. Many of them are devoid of care. And if you look at the data by the Women Alzheimer's Movement, a part of Alzheimer's Association, 1 in 5 women over 60 develop Alzheimer's. Unfortunately, such clear data is missing from our Indian context, but we really need it if we have to eliminate or kind of stabilize this gender bias in care. Female sex hormones, estrogen, increase in diabetes, obesity, and longer lifespan, and some genetic risk may have an additional risk factor for women in Alzheimer's. However, many also mention that since they live more and they are detected lesser, that's why the incidence is more. This is a fantastic book. Many of you, anybody interested, can read it. The 36 Hours Day, it's a fantastic read. I just sort of taking up 2 aspects. If you look at the second excerpt, daughters support their mothers in performing traditional gender roles, whereas the support for fathers was aimed at supporting their dignity, such as engaging them in jointly making puzzles and driving them to appointments. This actually shows the role difference in even caregivers based on a lot of gender stereotypes, social expectations, and hence it's a common belief that a female caregiver may be better, contrary to what the research shows that actually both can work at the same time in the same way. This is a wonderful research review, again freely downloadable online, Women and Dementia. So this is Women in Dementia Care Workforce. Many times they face difficulties like time pressure, multitasking, workload, problems of emotional support, and increased burnout. So there is indeed a gendered expectation existing. Talking about caregivers is just not how they look after the person, but their own care, detection, having a supportive environment, understanding what is happening, and their own leisure activities. So having a respite time for themselves, enhancing their coping methods, that all of us are together, it gives a feeling that, I am not alone in this. And so that they can have some personal time and respite care becomes very important. Caregiver burnout is very common, especially since care for Alzheimer's or dementia is very challenging. What are the signs? Loss of interest, anxiety, forgetfulness, tired, easy anger, easily frustrated. And remember, all of these, especially caregiver burnout, can lead to unintentional abuse. It can be physical, emotional neglect. It's not somebody's wanting to do it, but yes, it can happen. And if you look at it, caregivers also have their own health being compromised, their financial difficulties, and many of them needed to quit a job. And this is for the family caregivers. Paid caregivers have separate challenge. So few things that I would like to highlight, I think it will also be discussed in panel discussion, is have some respite time. Don't shy away or feel guilty about discussing your own problems, because if you are not fine, the core falls down, and give yourself the credit for the tough job that you are doing. Also, have some time for yourself, cherish your activities, because otherwise you will not be able to pull it. Ensuring dignity becomes very important in the affected person, providing autonomy, respecting their identity, addressing them by name, treating them as a person, not over-medicating whenever they have a problem, trying to understand the context of the problem. Why is this important? Because unfortunately, no medical textbook teaches this. This only comes when we learn from caregivers and we talk to individuals and, out of discussions such as this, but they form extremely important in caregiving. This is again something which, Dr. Subashini has already discussed. I would just like to highlight that not all is grim. Remember, if we have to start preventing Alzheimer's, we cannot start it at 60 years. When does it start? Right from birth. So early life, middle life, later life, if we really take care of these factors which can be modified, 40% of dementia risk can be reduced. And in an illness like this, even if we are able to delay the start of dementia by even a year, imagine the number of productive years that a person is going to get in life. This, I would like to highlight as one of the central messages of my presentation, is a wonderful resource. It's available online in multiple languages. It's like a workbook. Please go through it. The I Support for Dementia, it provides regular, systematized, organized resources for caregivers who are dealing with individuals who take care of loved ones with dementia. These are again some of the organizations who have a lot of freely downloadable material. These are a collection of different films on dementia. Many of you have watched Still Alice, The Notebook. Recently, The Father Came, which is a phenomenal piece. One of the very favorite Bengali movies recently was Bella Shuru, and I loved it. So make it your bucket list. If you want for more, I can always share it later on.
Because you work with caregiver Sathi, and maybe you can start off by, I believe you have some slides to share. So maybe you can start off by, talking about the caregiving aspect. And as you can see in the comment box, there are a lot of questions around caregiving. And like Dr. Debanjan said, it is essential to the dementia story. So you can start off, Bhavana, and we'll take it from there with all our experts. We can discuss the practical solutions and any tips that you all want to share, and also what are the resources available.
I'm going to talk to you about a couple of invisible stories. So this is the story of Sunil, a caregiver to his wife who has had dementia for 7 years. One of the things that he told me was that, I have a helper, she's good, and has been trained in basic paramedical support. But Deepa has dementia. I feel frustrated and overwhelmed. And I wish there was a caregiver who would help Deepa and me. Because Sunil is the invisible patient here as well. Then there is Ashima, who is a manager in a multinational. She says, my mom has been diagnosed with Alzheimer's and I live in another city. How can I help my brother access trustworthy medical and non-medical support so that at least he doesn't have to spend time looking for information? So there are caregivers who have to do the daily support. And then there are other caregivers who probably don't live in the same place, but worry equally. And they are in other locations. They are not necessarily the primary caregivers, but all of them are, let's say, in the constellation of dementia. So I'd like for us to take a peek into the world of caregivers. And I'm just making sure that I have sound.
I'm sorry.
It's okay.
What do I say about myself?
What did you do to take care of yourself?
Take care of myself?
Emotionally.
To be honest, nothing. There was a period when I had gone to the doctor and he said, "You're clinically exhausted."
You don't know which way you're heading. You don't know where to start or where to finish.
I can't trust anybody else with my husband. I want to do it on my own.
Focus on giving the level of comfort, giving the right treatment, supervising the treatment. You got to become a counselor sometimes you go to scold them like a parent, sometimes you got to be really loving and caring.
There used to be a time when I just slapped my husband, said, "What are you doing? Come on, try to understand."
At the end of the day, if anything happens, then I have to step in. So that responsibility and that onus does lie with me.
They put their life comes to a standstill.
It becomes literally like a role reversal.
You have to really recondition your mind to not feel guilty
and make you realize that this is a part and parcel of life, and that doesn't mean that you have to bring your life to a standstill.
So why did I do this for myself? Or why am I watching so much of Netflix? I feel I deserve it.
If I could find little time to sit down and paint, that would give me a lot of energy and happiness.
It's about being a doctor, being a nurse, being an oncologist, or being in palliative care, and one would take a lot of pride that saying that well, I've set up this facility on palliative care. That would be a matter of pride. But in one's own personal life, caregiving is pretty much a very thankless job.
So what I'd like to quickly take you through is that there is a certain context and environment in which we have caregivers. The socio-cultural context is that we are increasingly in urban nuclear families with fragmented communities, and the expectations from family for caregiving still hold, and that caregiving is a gendered role, like Dr. Debanjan also spoke about. And when it comes to incurable conditions or chronic conditions like dementia, the engagement and the role of the doctors is relatively less. And there is the unrecognized caregiver trauma. It has mental health implications for caregivers, which range from stress, depression, complicated or anticipatory grief, compassion or empathy fatigue, and the complex web of emotions like guilt, anger, frustration. 80% of the caregivers are women, and sometimes nearly 60% of them may be looking after children as well as looking after the elderly. This means that caregiving, especially for family members, is invisible and sometimes unrecognized and underappreciated and underserved. Caregivers tend to deprioritize themselves, as well as they are low priority for others, especially in the light of someone who is suffering. So what I'd like to talk to you about is the tightrope walk of what are the challenges as caregivers for self-care? What are the challenges of self-care among those who are caregiving? It would be lovely to hear your thoughts. So when I say self-care, what are some of the thoughts and feelings that come up for you? Do leave them in the chat box, and we will pick them up. Caring for someone fundamentally is about keeping hope alive. A hope of a life, nurturing life, yeah? And what goes into caring has many types of labor, right? One could say there are three aspects of this labor. What you most see is like this woman whose eyes are open is the physical part of the labor, right? You see it, that, there are daily activities that need to be supported. What you don't see and is slightly in the background is the mental or the intellectual part of the labor, like, organizing, ensuring that there is a routine, ensuring there are things that are happening, and so on and so forth. What we don't see at all is the back, the person with the back, which is the emotional part of the labor, which is like saying all is well and all will be fine and we will get through this, and that we have hope. This is emotional labor, and this is perhaps the most difficult part of caregiving. To be able to deliver this work as caregivers, we need a fuel. This fuel is called compassion, and this is not, an a limitless reservoir. We run out of compassion as well. So how do we ensure that compassion is maintained at the level of the care that we want to provide? We can ensure that when we are able to take care of ourselves, because providing long-term care is like running a marathon. If you were to hold a glass of water, you can probably hold it for 10 minutes or 20 minutes. But if you had to hold it for 2 days or 2 weeks or maybe 2 months, it would be very, very hard. You have to be able to give yourself rest. So you have to be able to understand that even the simple act of holding a glass of water can cause invisible stress, and you need to build resilience. The other big factor is that socioculturally, self-care is considered selfish. So a lot of caregivers sometimes feel guilty about caring for themselves because it might be perceived as, I'm caring for myself, how selfish. A good caregiver in our mythology, like Shravan Kumar or Savitri or Ram, were able to sacrifice themselves for the care of their loved ones, right? Mm-hmm. And if I cared for myself, then what am I doing? But I think it is important for us to remember that caring for someone is not just who we are, our identity. It is also something what we do, which is our role. So in addition, we need to be able to separate these two things. When we remember that caring for someone is something that we do, we will be able to take help for it. It is important to understand that our overall well-being has many parts. And as someone who may get dementia, or who might be at the risk of dementia, or as someone who's caring for someone else, it can be easy to break it down. If you break down well-being, you can break it down to physiological, psychological, and spiritual aspects of our living. And then there is our interface with the world, which is our social, financial, and legal aspect of our living. What energizes us is if there is an alignment between our life and work purpose, and most importantly, whatever is our creative expression. So whatever is your unique hobby, whether it is cooking or it is singing or it is motorcycle riding, it could be your creative expression. It is important to have a balance in this because stress is caused by an imbalance. And if we don't address this chronic stress, it can lead to mental health issues. I'm going to quickly move to what it takes to sustain self-care, which is building resilience and having your own infrastructure. Building your infrastructure, what will support you for the long term, for a long life, which can have the risk of dementia, either for yourself or your loved ones, has 4 parts, which is financial infrastructure, legal, physical, and emotional infrastructure. So I think from a practical tip standpoint, I think it is important for us to break down our support system and say, do I have a good financial infrastructure? Do I have a good legal infrastructure? Do I have a good physical infrastructure or support system? And most importantly, a social or an emotional infrastructure, because it supports me and then I can support someone else as well. And that is fundamental to, to being human. At the foundation of it all, I believe very strongly, is having a sense of humor. I think life can be funny and life can be weird and life can be difficult. But if we can have a sense of humor as we navigate life, I think we can overcome any situation. We need not learn everything about it. And finally, I would like to say that there are only 4 kinds of people in this world: those who have been caregivers, those who are caregivers, those who will be caregivers, and those who will need caregivers. If we are all caregivers, then it is important for us to remember that Zindagi is beautiful.
Thank you.
Life is really beautiful, irrespective of dementia. And living a full life is our responsibility to this gift. Happy to take any questions.
Sure. Thank you so much, Bhavna. I would request Dr. Subashini also to join the panel. Yes, I'll just add you back. One of the questions I'm seeing increasingly in the chat box, and I'm not taking that question as of now, we'll take everything later, but very quickly, there seems to be many caregivers do not know if we have facilities, if we have support systems that can help with caregiving. Rajeshwari, I would like you to also come in here in a bit, but I want to know from all of you what your thoughts on this are. Are things improving for caregivers in our country, and how?
Sure. Yeah, there are a lot of support systems, and I think it is important to recognize what is it that works well for you. You might need a support system to first simply understand what is the intensity of care that you need. So can you talk to somebody who can help you at least plan out the infrastructure that I was talking and the care coordination that you need to do, given your unique circumstances, right? Each one of us has a different family structure. Each one of us has different people, different age groups, different things to look after. So defining your care coordination structure is very important. So to be able to talk to somebody who's like a care advisor could be one step. And then understanding that which part of your, structure is not working well. Is it the physical, help that you need a little more of, financial or emotional? And if it is emotional, then looking at, do you need counseling or do you need therapy or do you need coaching, making that decision. And then, of course, if it is, what is the extent of burnout? So if there is a severe extent of burnout, then what are some of the things that you can do yourself? Or can you join a support group, or can you, be a part of a recovery program? This is what I would say quickly before, and let others join.
Thank you.
Yeah. So I was telling you about the structured caregiver intervention that we are doing. So it's a once a week session. Each session will focus on a specific topic. The initial ones being about dementia, and later how you can communicate with your loved one, and how you can manage, how to identify the triggers for bad behavior, and so forth. So it will be very helpful for someone who is caregiving. Please do keep in touch if you require such an intervention.
Yeah, can you hear me?
Yes.
Okay. So as I was saying, that Dementia India Alliance is a registered society. We started this primarily to bring help and build hope for caregivers, the most ignored community in this entire dementia journey. So, which is why a lot of people who have been service providers, about 12 of them, 8 of them have been providing service for dementia across the country, and along with a few family caregivers who are being CEOs of various companies, they all came together to start this organization called Dementia India Alliance. So what is the purpose of Dementia India Alliance? Is precisely what we Bhavana expressed. There are so many emotions that we go through when we come across our elders, our loved ones being discovered into this disease. We first are in the denial mode. We don't want to accept. Oh, my dad was a pastor uncle. How can he suddenly become like this? Or, so there is a denial mode both from the person with dementia and from the family. They cannot accept it, and they brush it aside as an age-related problem. Then once they see a very significant change in behavior, then they go through, now what do I do? Do I go to a psychiatrist? Do I go to a psychologist? Should I consult a counseling? Where do I go? And the myth about taking somebody from the family to a psychiatrist. That is still there. The stigma attached to it. We can proudly tell our neighbor that we are going to meet a cardiologist. But tell me one person who will be, telling that I'm going to meet my, psychiatrist today. So that is another challenge that, caregivers, families go through. Where do I take my parent? How do I do this? Is this age related only, or is it something beyond that? So that's another, confusion that people go through. Then having, let's say somebody has been detected with dementia, then as doctors were mentioning, each individual goes through a different journey. It's not like, A, B, C, D you do, and then you can take care of the patient. It is not like that. Every individual and every day they behave differently. So you need hand-holding. You need to have help available at your beck and call. Saying, my father's throwing the food, he's not eating, how do I handle it? Or he's just beating himself. How do I handle this? So these are some of the challenges. And then, where do I go? Is there somebody near me who can supply a caregiver, a trained, certified caregiver, who can come home and look after my dad or mom? So these are some of the questions which I went through personally as a family caregiver, and I'm sure most families go through this challenge as well, which is why recently we have at Dementia India Alliance, we've launched a national helpline, which is manned by psychologists and social workers, very experienced in this field, who you can just call and ask them, clarify your doubts. They will guide you in situations. Yes, I will give you the number. It is very easy to remember, 8585 990 990. We've just started, so it will be manned from 9 o'clock to 6 p.m. to start with in 5 local languages. We hope that, we want to be a national platform for everybody, every union territory, every state. We are able to take this national helpline, and we are able to provide service to all of them. And more and more languages, depending on what kind of calls we get, we will be introducing. So that is the first service we have launched. Please, I request all caregivers and the family members who joined today to spread this news so that more and more people can benefit out of it. The second service that we have launched is an online screening, which is free of cost. So, like everybody was saying, it can happen to any of us. Nobody is, not susceptible to this. We don't know when it will hit. So the minute you see an elderly behaving a little differently from his normal pattern, and you want to get it tested, please call the helpline, and our experts will take an online screening for you.
Wrap up this panel. We have overshot our time and we have some questions in the chat box. So I just want to quickly wrap up this panel with one question that all of you can probably chime in. There's a lot of talk about training for home caregivers, for family caregivers. Is it important? Because many people ignore that. I'm getting a paid caregiver. Why should I get training? Is it important? And if it is, why is it important? And where can, I'm guessing training is available in all the organizations you're talking about. So please tell us, is it important? And if it is, why is it important?
Yeah. So I'm just going first. I'll be brief, and considering I have to leave actually. So thank you all for your inputs, and I think it's important for us to learn from the caregivers as well, since meet like this always helps us, share our knowledge. Couple of points. I think caregiving is a distinct journey for everyone, and as all of you mentioned, there is help. But I'm really thankful to Bhavana for putting that slide. I think organizing the care becomes the most important part of caregiving. legal issues particularly, many times it's just not met and it's kept for the last moment. Hence, I think it's very vital for each and every one of you who are caregiving to sit and have a plan for future, for yourself and for your caregiving. That's one. Second, with regards to the question that you asked, Reshmi, the person who is involved in care forms the core part of dementia care. And I keep repeating this. Yes, paid caregivers have their own role, but the family caregivers, for them, I think the intervention that Dr. Subashini was mentioning about, as well as training, becomes extremely important, not only for their own self-care, but also for them to understand the challenges that are associated with the dementia symptoms, especially the behavioral and psychological symptoms. And many times in all of these, taking care of your own self becomes a guilt trip. If that can be taken off, if each of the individuals who are involved in caregiving can have some respite time, that immensely helps not only them, but also the person they're caring for. Thank you.
Thank you. Would any of you like to add anything to it? Before we...
I would simply say that, sorry.
It's okay.
Should I
Go
go
on.
ahead? Yeah.
Yeah, go ahead. Go ahead.
I would simply say it like this. That you see, our education system and our professional experience does not equip us to be caregivers. We are taught everything except caregiving, and caregiving is the one thing that we need to know, because we will be caregivers whether we are bringing up children or we have partners or we have to care for ourselves simply, and certainly for older adults. So caregiving is not a thing that just because you're a woman you will have it, or just because you are now expected to care for somebody you will know how to do it. It's a skill. It's something that we have to learn, and it is something that has many moving parts. So, it is not something that you can know everything about at the same time and know, you could have done caregiving for 12 years or 20 years and still be stumped by a new circumstance. So, learning to provide care or breaking it down or sharing it with others is certainly something we have to learn, especially when we have our emotions involved with the person that we care for. Sometimes our emotions could be that we love that person too dearly, and sometimes they can be that we have emotional baggage with that person, and we are now supposed to take care of that person, so it's complicated. In either of the cases, I think it is important to recognize how will we deal with caregiving not at the cost of ourselves. How can I still pursue my career, my ambition, my other relationships, etc., and keep a nice balance with, with caring for someone, because caring for that person either is my duty, my love, or, it is something that I want to do. That is why learning to care is an important thing. Also, like I said in my presentation, caring for someone draws your emotional reservoirs. So it is very important to learn how to replenish your emotional reservoirs. Again, it's a skill, it's a practice, and all of us need to learn it.
Thank you, Bhavana. Would you like to add anything, Dr. Subashini or Rajeshwari, to this, or can we move on to the questions?
Yeah, I do want to add to this.
Yes.
Dementia India Alliance proposes to have, a training facility where we will be training caregivers, and we have a very ambitious plan. We want to have at least 100,000 caregivers trained and certified in the next 5 years. So, caring is one, caring for children is one type, caring for elders is one type, caring for people who are afflicted with dementia is a totally different ballgame. So you need to go through the training. Unfortunately, none of our, nursing colleges curriculum, have this for mental, ailments. They don't get trained at all for mental ailments, and they don't. Physical ailments, they are very well equipped and they cover that. So we need to, have, we want to call upon all these retired nurses and people who want to take this up as a career. We want family caregivers to come to us and take training from us so that, we have a huge force available to take care of our elders.
Thank you so much. I'll move on to the questions now. I'm sure there's so much we can share, but sorry, we have limited time. One of the first questions that came in is from a younger person, I'm assuming. How to reduce forgetfulness and proactive steps that people could take when they are younger, physiological measures they could take to reduce forgetfulness. Would you like to answer that, both the doctors, any of you?
So as I covered in the session itself, having a healthy lifestyle is the base for everything. Not to be stressed. If at all something is stresses you, get help. Have a healthy lifestyle. Be physically active. Restrain from smoking, alcohol, and mostly it's healthy lifestyle. All ages. It is the same for all ages, provided if they are over 60 and they have blood pressure, diabetes and other comorbidities, everything has to be under control and maintained. That's the only difference.
Thank you. And there's another question. Can consuming sweets daily increase the chance of dementia? What types of foods are advised for prevention?
Yeah, I think, there is no direct evidence that increased sweet consumption can lead to dementia. But of course, it increases the risk of diabetes and other metabolic problems. I'm not telling anybody not to have sweets. I'm a personal sweet lover myself. But just have a watch on whatever you're doing. Don't do it in too much of excess. Normally, I don't want people to tell the doctors are scaring us away. So, yes, start early. Healthy lifestyle, as Dr. Subashini mentioned, is really a good boost. And I think keeping the body and the mind active is the best thing. And by active, it doesn't mean that you always have to learn a lot of languages or you have to master academic skills. Somebody in a shop doing, just calculating in mind the whole day is probably has a more active brain than I do. So it's all important that you just stay in some of the other things that you like doing and don't stop doing that. Socializing is a very important factor. But increased sweet consumption together with other symptoms, as I mentioned, can be early symptom of a dementia called frontotemporal dementia. So if there is a sudden change in dietary pattern, that's one of the reasons you need to seek consultation.
Thank you so much. It's not a question, but it's basically, if a doctor could highlight as an advice to caregivers that social isolation of the patient should be avoided despite their behavior being erratic or indiscreet. I think Bhavana, the doctors here, Rajeshwari, or any of you can talk about this. Why is it important?
It's not that social isolation is never recommended, because as I told, and all of us are telling here, that you need to just keep the brain going in whichever way possible. So, I would not prefer using the word erratic, because I believe every behavior has a context. So if somebody is behaving in a certain way, we rather see what is preceding, what is the context, rather than terming it as abnormal or erratic. I'll just give you an example. Sorry. If I am unable to understand what's going on, if I have dementia, and somebody suddenly comes and starts pulling at my clothes to give me a bath, which person will not resist? So that, to the caregiver or to the other people, it may look to be a very quote-unquote erratic behavior. But for me as a person with dementia, I don't know what's going on. So understanding the behavior becomes very important. And once you're able to manage that, keeping the person in social circle is one of the most important things that we can do for them.
I'd like to build on what Dr. Debanjan has beautifully said. So why would you want to keep somebody in isolation, right? We would want to keep somebody in isolation because we are either afraid that they will do something that is not socially acceptable, or we are ashamed that if they do something, it reflects on us. I think it is important to recognize that both these things are our emotions. That we are afraid this person will do something, and out of fear, we keep them isolated. And the second, that we are ashamed that, let's say, sometimes somebody will say something inappropriate, or will probably take off their clothes, or will probably do something which is socially inappropriate, right? So if we can recognize what is making us do what we do, we will be able to dip into our compassion and be non-judgmental, and recognize that social stimulation is a way for us to support ourselves as well as others.
Thank you for that, Bhavana. It's very, very important. One last question. This is for both the doctors. I think Dr. Debanjan spoke about reminiscence therapy. So the person has asked, how can I ask a doctor for something like this? I have visited doctors, but I've never come across this therapy.
So reminiscence therapy need not be done only by the doctor. It can be done by caregivers as well, the family itself. There is something called life story book. We can collect photographs of the person with dementia from their childhood until now. They can mostly good memories. We can stack them, write about that memory. Probably, I think most of you would have watched the Notebook movie, right? That is what is happening in that. He's been, talking about the whole life every day, right? That is only reminiscence therapy. It can be done by the family caregiver themselves, even whoever, a professional caregiver who is now with us, they can also do that. It's nothing but talking about each and every positive memory, which is going to improve their mood, in turn, their quality of life. So it's that simple. It's not very complicated. Even managing a person's behavior with dementia, it takes only common sense. We have to figure out what the trigger is. Most of the time, we would be the trigger, the caregivers would be the trigger. So that is where we have to focus on. And that is why, and someone had asked about why a family caregiver has to know about dementia and caregiving when there is a professional caregiver. So the person with dementia shares a bond with the family caregiver. So the family caregiver do interact with them more often, right? So the family caregiver is the first person who has to be psychoeducated, what dementia is, what is the reason for the behavior and the repercussions because of that. So it is better. It is mostly the family who triggers many behaviors.
So sort of, if anything you want to add before we wrap this session up. Dr. Debanjan, would you like?
Thank you, Reshmi. Yeah, I think not everything is that negative. I think caregiving can also turn into a very positive and self-reflecting, self-worth experience. I can talk about it. I still remember the great memories I have with my granddad. Many of you do. So stay informed. Talk to your doctors, to your support, build a support system, take care of yourself. Humor is a fantastic thing. Thanks, Bhavana. And let's have more such sessions. It really makes all of us feel that we are not alone. Thank you, Reshmi, for having me in the panel today.
Thank you. Thank you. Bhavana, would you like to go? And in fact, I see a quick question from a long distance caregiver. If you would like to probably address that as a wrap up.
Yeah, sure. First off, thank you to Silver Talkies. Thank you for doing the work that you do, and thank you for organizing this. Thank you for including me and giving me an opportunity. Delighted to be here. It kind of gave me many perspectives, new connections, all of which, thank you. Yeah, so the primary caregiver may be in denial for a variety of reasons. And I think we must recognize that denial is, often a phase of grieving, right? It's a sense of loss. When we don't want to accept is because things are changing and things are bringing sadness or grief or loss. So it's important to be kind and compassionate to that person, and recognize that, and Dr. Debanjan has already mentioned that it is a part of the process. I think acknowledging that or holding somebody's hand to say, we are going to walk this path together, can possibly help the person deal with denial. Of course, there could be many other ways of dealing with this, but obviously we cannot shove something in their face if they are not ready for it. I think it is important to have continuous conversations, to build a certain rapport, and to find the right time for the person to accept when they are willing to accept. Denial is like, I would like to deny because I would like to also avoid the pain that comes with it. Yeah. So if I can recognize that denial is just simply a way of coping and it's simply a way of managing my pain, then my ability to find creative ways of coming to the same page will increase. Having said that, I think what I'd like to say is that people who have dementia and people who care for those who have dementia are all, we are all patients at some level and we are all caregivers at some level. I think people who are navigating dementia can teach us patience, can teach us, can cause spiritual growth for us. And like Dr. Debanjan said, caregiving can be a very powerful part of our personal and spiritual growth. It can be beautiful. It can leave us with lots of meaning in our life. Having said that, I think it is important that we don't feel alone in this, and we aren't. We aren't the first generation of caregivers. We might be the longest caregivers the world has ever seen, but we can be in this together. So there's so much that I'd like to say, but if there's anything that anybody would like to get in touch with me or know about what Caregiver Sathi does, invite you to have a look at our website and see some of the programs that we are doing. I think the most important way to build empathy, compassion, and caregiving is to volunteer. When we do Niswarth Seva is when we build our muscles of caregiving and compassion. So I invite you all to consider volunteering your time, skills, and supporting someone who cannot give you anything back in return.
Thank you so much, Bhavana. Rajeshwari, would you like to say something and before we wrap?
Yeah, so all I want to say to everybody out there is don't shy away seeking help. We're all there for you, to support you. There are many organizations to support you. Just go out there and ask, and you will get help. Okay, and likewise, I also want to add in to what Bhavana said. Caregiving it has to start from childhood. It has to be ingrained from then. So we at Dementia India Alliance, we want to involve youngsters, the youth, into this journey, and we want to make them foot soldiers to spread awareness. And so, they also understand what elders go through, what their parents go through, and they are ready when they become a caregiver. So seek help.
Thank you. Thank you for that. And like Dr. Subashini has shared in the chat, do share the information you have received today with as many people as you can. So thank you all for it. Thank you, Dr. Subashini. Thank you, Dr. Banerjee. Thank you, Bhavana. Thank you, Rajeshwari. And